Unit 6, Communication and Behavior in Dementia Care. Impaired cognition equals impaired communication. The definition of communication is the interchange of information. Let's talk about the challenges and the best communication approaches with our people who have dementia. First of all, the challenge of processing. The first best communication approach is to speak in short sentences and avoid lengthy run-on sentences packed with steps and steps. For example, Millie, your daughter is coming to see you today. An example. Would you like to get washed up? Example. Turn the water on. Example. Wash your face. The second communication approach for processing difficulties is to use visual demonstration and tactile, hands-on cues to go with the words. An example, while saying, "Please brush your hair," spontaneously demonstrate the movement of hair brushing. Don't use verbal communication alone. This often leads to lack of response, with the staff member concluding that the resident cannot or will not do the activity. The third communication approach, wait for a response. Allow the person extra time, 10 to 20 seconds, to process the communication before proceeding, and do not distract the person during this process. Avoid talking faster or louder if the person fails to respond. Memory challenges. The first communication approach is use nouns and avoid pronouns. For example, nouns would be like shirt, wheelchair, nurse, or book. Avoid pronouns such as he, she, it, they. In order to know what a pronoun is referring to, it is necessary to remember the subject or object of the sentence. People with dementia often do not possess the short-term memory necessary. Second approach, speak in short sentences and avoid lengthy run-on sentences packed with steps. Third approach, used closed-ended questions. Example, would you like orange juice or apple juice? Do you want coffee, tea, or water? Would you like to wear the blue shirt or the red shirt? Attention challenges. Communication approaches for attention challenges include make direct eye contact, unless this is culturally unacceptable. Do this before delivering your communication, and stand or sit in front of the resident when communicating. Try not to communicate from behind or off to the side of the resident. The next communication approach is lead a sentence with the person's name. Example, Paul, please stand up. Do know if they have any kind of title such as doctor, sergeant, pastor, or coach. The next approach is be sure to gain and maintain the person's attention before proceeding. And the last approach to help with attention problems is to eliminate all unnecessary stimulation and distractions. Remember, selective and divided attention is difficult. For example, with permission, turn off the client's television in their room when he or she is engaged in ADLs. Behavior challenges. Communication approaches that should be used. First, be sure to gain the person's trust and agreement before proceeding. Next, be aware of the message your tone of voice, body language, and facial expressions are sending, in addition to your words. For example, keep volume at a normal level, or you might frighten or intimidate the resident. Unless, of course, the resident is hard of hearing. Be sure to know all the communication approaches for the challenges that people with dementia face when trying to meet their wants and needs. Communication and behavior. There are two types of communication: expressive and receptive. Expressive. This communicates the needs using speech, body language, and facial expressions. Receptive. This is comprehending the message from others. Look at our communication loop in this diagram. We have the person with cognitive challenges trying to express their wants and needs to staff, relatives, and other clients. This requires verbal, nonverbal, words, and expressions. The communication loop consists of a sender, a receiver, and a message. Breakdowns in the communication can occur at any point in this loop. For example, the way that a person with dementia communicates may be primarily through nonverbal communication, and staff must interpret and respond accordingly. It is important for staff to interpret behaviors as forms of communication and adjust his or her communication in response. Make sure that your nonverbal communication matches your verbal communication. Clients will always read nonverbal first. Perception is a reality. Behavior is communication. Look at the picture of the little boy in the wagon. What do you suppose he's trying to communicate to his parents? He's not using words, but his expression and his sounds, his behavior, definitely tell the parents that he is not happy. A loss of cognitive ability has an impact on behavior. People with dementia often communicate through negative behaviors. Dementia often causes people to act unpredictably. It is important to recognize behavior as communication and to look for the trigger behind the behavior. Some examples of communication through behavior would be sundowning or resistance to care. You need to perceive negative behavior and find out what it's based on. What unmet need is there? What does that behavior mean? Behavior problems usually arise out of pain. This is the number one cause of negative behaviors. Fear, inability to express an unmet need, loss of sense of self, inappropriate expectations from the caregiver. Sources of behavior are also predicting factors that are sometimes out of the control of the client or the caregiver and should be recognized by the caregiver as such. Remember, the client is not able to recognize the precipitating factors such as they are due to their cognitive impairment and their cognitive age. As many as 50 to 90% of individuals with moderate to severe dementia display behavior problems. Behavior disorders tend to get worse as the dementia progresses. Up to 90% of behaviors may be triggered by the caregiver or the environment. When do we need to decide if there's a behavior? We need to devise a behavior management plan. When behaviors get negative and impact the caregiver's ability to care for a person with dementia, or the person with dementia has limitations in their independence and occupations. Things we need to ask when we're developing a behavior management plan. The who. Who was involved in the incident? What? What was the behavior? Where? Where did the behavior occur? And are there any patterns? When? When did the behavior occur, and are there any patterns? Why? Why did the behavior occur? What factors preceded the behavior? Consider elements such as pain and non-pharmaceutical ways to intervene. How? How did you respond? How effective was the response? How is the person now? The why and how are the most important questions when managing behavior. Make a plan to have in place. With the how, you should incorporate the client's interest into the behavior plan. Behavior problems. These can be things like resistive to care, such as during ADLs or leisure activities. Physical and verbal aggression, such as hitting, kicking, biting, screaming, threatening, or cursing. Anxiety, such as hand-wringing, pacing, or fear of being alone. Sundowning, a decline in behavior in the afternoon or early evening. Transfer trauma, upset behavior after a move. This often happens when they go from home, the hospital, to a long-term care facility. Or it could happen when you change their furniture around, change the room they're in, or change their roommate. Other behavior problems might be sad, mood, or depression, such as tearfulness, feelings of worthlessness, and low interest. And lastly, wandering. Some approaches to minimize and prevent behavior problems. If able, come back later. Incorporate interest and routine. Gain trust and agreement. Provide as much control as possible, giving choices. Reduce stressors. Check for pain. Help the resident develop relationships with you and others. Minimize time left alone. Listen and support. Anticipate and meet their needs. Engage the resident in valued activities. Tell the resident what to expect and what you are going to do. Provide one-on-one time. Distract or redirect. Stay calm. Offer positive touch. And validate their feelings. Stay in a routine. Decrease isolation and develop rapport. Unit 7, Supporting Families. Families are typically distraught and tired when making the decision to move their loved ones into a long-term care community. Often, if the resident-to-be has dementia, the resident does not recognize the need to move into a community and believes that he or she is fine. This can lead to a lot of family guilt and can also lead to what is called transfer trauma for the new resident. Let's look at understanding of family members, relatives, and friends of those with dementia. When we're looking at the understanding of family, we need to keep in mind transfer trauma, not just to what's happening to the clients, but also how this is affecting the family, the spouse, or the kids. Often, the caregivers have been taking care of their loved one for many years. Another thing to consider is guilt or anger. The loss that the family is going through. They're grieving the loss of someone they knew. Watching that person change and diminish independence and abilities is hard on a family. You need to understand what the family is going through. Understanding by family members, relatives, and friends of those with dementia. Things to consider when understanding by family members. Who is the person inside? Who we see may not be the person that the family and friends knew. Do the family understand the stages of dementia? Is this something we can help them understand? Remember to always look at the client's remaining abilities and their best ability to function. What are the best approaches when it comes to behavior and communication? Creating a community for dementia clients requires a group effort. An interdisciplinary approach is key to creating a thriving environment for dementia clients. This concludes Unit 6 and Unit 7, Dementia Care.